All right, so lasers and alternatives. So this is quick. It's not going to be all inclusive, but it might just provide an opportunity to hear some facts that could be tested and open you up to some weaknesses you might need to study further before your test. So we'll talk first about lasers and then quickly about some alternatives to laser therapy. So thermal laser photocoagulation therapy, medical medicinal lasers are a standard source of light. They've been used, since the 70s to treat some retinal vascular disease. I think the um, first um, DRS study was in 1970 that proved the benefit in um, diabetic disease in the back of the eye, that photocoagulation laser is of benefit. And so since the 1970s, it's been used in the 50s. The xenon arc laser was discovered in 1960. It was advanced in the 1970. They started using it for retinal coagulation, which showed the benefit of stopping proliferative disease from continuing to progress. Thankfully, today we don't have to use it in that sense as much as we did in the past. But for your historical knowledge, it's been used for quite some time. The most common treatment of laser in the eye is evidence of photocoagulation. So that's where you have a temperature effect heating up. You have the effect of coagulative necrosis that occurs from the increase in temperature. You want to keep that temperature. I don't think any of the settings are really important from this perspective, but less than 100 degrees Celsius because you don't want to have so much that you vaporize or like burn through the material. You don't want to burn through the eye itself, but you want to have enough of a thermo effect that you're causing desaturation that has coagulative necrosis occurring. And that's different than the other types of lasers, which we'll talk briefly about, where you have like a photochemical effect. And so, like PDT, where you inject a dye in the veins, it gets into the eye. You then use the laser to have a photochemical reaction, causing free radicals to form, which then causes the necrosis in that area. So, that's PDT. Um, and so there's some different types of lasers that are commonly tested in the anterior segment and optics. You might discuss photodisruption. And so you would have a femtosecond laser that's causing tons of microparticle disruptions effect to where you're having a connection like a YAG laser or a LASIK laser to have a disruption. So that's not thermal, it's not chemical. So there's different types of lasers that go in the eye. The majority of retinal lasers in the posterior pole are temperature thermal related, and some are chemical. And so laser, I think I heard this tested once, but what does laser actually stand for? So that's light amplification by stimulated emission of radiation. And so as we talked about, most commonly tested in the posterior pole was a temperature rise causing denaturation of proteins, causing coagulative necrosis at the local site of where the temperature is applied. So we talked about different types of lasers, and specifically you have the argons, diodes, dyes, multicolors, micropulse, and then we briefly will hit on PDT. Um, the delivery systems most commonly used, slit lamp with contact lenses on the eye. The next most common would be an indirect ophthalmoscope, and then followed by your camera-based navigated systems. And so they have, retinal tracking. So a lot of, especially retinal clinics, utilize these today, where you can kind of block off areas and say, don't hit the fovea, don't hit the optic nerve, and you're doing a proliferative diabetic case. And so you're doing wide field laser in the periphery and areas of non-perfusion. You can kind of pre-program them so you have a navigated retinal system. And then using things like endolaser in surgery, where you're trying to tack down areas around tears and trying to make sure that post detachment treatments are effective. So the useful pearls you need to understand from a written boards test perspective is just the visible light spectrum. So that's from that 400 to 700 nanometer wavelength. And I think it's easy to remember the Roy G. Biv mnemonic. And so you're going to start with the longer one is red is 700, goes to that down to violet, which is 400. Your longer wavelengths are generally produce a deeper burn and are more painful. So your red ones are going to have that more discomfort for the patient, but they're going to have a deeper burn and be a little more effective. They can get through things like blood. So we'll talk briefly about why you might choose different colors. Your retinal burns are going to result from that secondary heating that we talked about with most lasers. You're trying to increase the temperature in the posterior area. And then that intensity of the burn is related to the size squared. And so you need to be able to understand, you got to be careful in where you're focusing and how a defocused laser can cause harm. And so if you have a larger area, you could cause more harm. And so just understanding your optics and where you're focused on is very important. These are two graphs in your BCSC that I think are worth memorizing. We talked about the Roy G spectrum, and so that red closer to 700 down to violet closer to the 400, and being able to understand that visible spectrum. Your infrared's the above 700s, and then your ultraviolet light is less than the 400. And then the bottom right graph is a graph that shows where common wavelengths are absorbed by different materials in the eye. So melanin's a really effective absorber of the green, yellow, and red and infrared wavelengths. And so you should be aware of that. Macular xanthophylls readily absorb blue and minimally absorb yellow and red. So you shouldn't be shooting blue into the back of the eye where you're going to hit right in the fovea area. It's highly concerning to have reflective patterns, especially because blue light can be scattered more easily by a cataract. And so we stay away from blue lasers because you can get scattered easier and it can absorb more readily in the central portion of the back of the eye. And then hemoglobin is easily absorbed by blue, green, yellow, but minimally absorbed by red. So that's another reason why we use red more commonly in retinal areas because we're dealing with blood in the eye, and so red can pass through more quickly. We talk about light scattering issues. So the cornea can scatter, a cataract can scatter, and vitreous hemorrhages can scatter. So anything that can kind of disrupt your clear image to the back of the eye obviously can have a scattering effect on the laser being shot in the eye. You should be aware of that. So what absorbs, we talked about lens can absorb blue, and so you can cause a little bit of cataract. It can scatter the blue light, and then it's going to absorb in the melanin more highly than other areas. So stay away from blue lights shooting into the eye. Your blood hemoglobin, we talked about just to hammer home, is commonly tested principle. If you have blood in the eye, it's less absorbed by red lit wavelengths, and so trying to use that to laser when somebody comes in with a bleed is your most likely answer. And then the rest of this I'll let you read through, but those first two are the most commonly things that are often tested on your exam. All right, so you want to, these make common sense here, but just notes for you guys to read through. You want to select the parameters that are going to, align with your treatment goals. Your laser wavelength selections depend on the specific goals of treatment, degree of which photocoagulation must be targeted. The area, which is a combination of your depth and diameter of effective coagulation, is directly related to the intensity